All right, today we're jumping into one of the most intense, high-stakes races in all of medicine, the absolute battle to save a heart during a heart attack. We're going to be decoding the brand new 2025 guidelines that are completely rewriting the rulebook for the doctors, the paramedics, and the nurses right there on the front lines. Let's get into it.
So, what's with this number? 10 minutes. Think about that. According to the brand new guidelines, that is the absolute max amount of time a first responder has from the second they meet a patient to get an ECG and, this is the crucial part, to figure out what it means. In those 10 minutes, well, the entire course of a patient's life can change, because that little electrical snapshot, it holds all the clues to life or death.
And, this is a massive deal. I mean, for the first time ever, the rules for all kinds of heart attacks, the ones with that classic smoking gun pattern on an ECG and the ones without, are all being brought under one single roof. So why do that? Well, it's because medicine now gets that a heart attack isn't just one or two things. It's a whole spectrum. And this unified approach means a much more coordinated, much more effective response no matter how that heart attack decides to show up.
Okay, so here's our roadmap. We're going to follow the patient's journey, starting with something called a brand new chain of survival. Then we'll put on our detective hats and decode the heart's electrical signals. After that, we'll look at the incredible race against the clock to open up a blocked artery, explore all the new drugs in the medical arsenal, see what it takes to restart a stopped heart, and finally, look at a totally revolutionary new focus on life after the crisis, the recovery link.
First up, we're looking at the very foundation of emergency cardiac care. And guess what? It's evolved. We're moving way beyond just surviving the event itself. As you're about to see, this new framework is all about the complete patient journey.
Right, so the classic chain of survival, it had 5 links that we all knew. But now, take a look at number 6. The 2025 guidelines have officially added recovery. And that right there is a paradigm shift. It's a signal that the job isn't done just because the heart's beating again. It really emphasizes that true success is when a patient can return to a full, functional life.
Okay, let's get into the detective work. That 10-minute ECG is the very first and maybe the most important clue. You see, it tells a story written in electrical waves, and the doctors, they have to read it perfectly to find the real culprit, the blocked artery. For years, this was the main thing everybody was trained to look for, a STEMI. You can think of it as the undeniable smoking gun on the ECG. It's this clear, obvious pattern called ST segment elevation that basically screams, hey, a major artery is 100% blocked right now. This is your textbook heart attack, and it requires immediate all-hands-on-deck action. But it's not the whole story. Now, this is where things get really interesting. The new guidelines put a huge emphasis on finding these STEMI equivalents. These are subtle, sometimes really misleading patterns on the ECG. They don't look anything like a classic STEMI, but they mean the exact same dangerous thing. A major artery is totally blocked. A perfect example is a pattern called De Winter T waves. They can look almost harmless, but they're just as deadly and need the exact same urgent response. So what happens when you're trying to find clues, but the crime scene, let's say, is already messy? How in the world do you spot a heart attack in a patient whose ECG is already abnormal to begin with? Maybe they have a condition like a left bundle branch block, or LBB.
Well, this is where you need a special kind of decoder ring, and it's called the Scarbassa criteria. See, an ECG with LBBB already looks abnormal, so it can easily hide the signs of a heart attack. These criteria help doctors look for very specific clues, things like electrical signals that are way bigger than they should be or are moving in the wrong direction, that help unmask that hidden danger. It lets them find the heart attack that's hiding in plain sight.
Once that diagnosis is made, doesn't matter if it's a classic STEMI or one of those hidden ones, the mission becomes simple and honestly brutal. Get that artery open. It is a frantic race against time because every single minute that ticks by, more of the heart muscle dies.
And that race has targets. The best option, Plan A, is something called PCI. That's where a cardiologist actually snakes a tiny catheter up to the heart and physically opens the blocked artery with a balloon. The goal is to get this done in under 90 minutes from the moment the patient hits the hospital door. We call it door-to-balloon time.
But what if you're in a rural hospital and the nearest place that can do a PCI is hours away? Well, then you have to go to Plan B, really powerful clot-busting drugs. And here, the clock is even tighter. The door-to-needle goal is to get those drugs into the patient's vein in under 30 minutes.
Now let's talk about the pharmacy. Alongside physically opening the artery, doctors use this whole cocktail of advanced drugs to fight clots and keep the patient stable. And the 2025 guidelines have made some really big updates here.
So, one of the most important choices is picking the right weapon to stop platelets from making more clots. For years, the standard drug was clopidogrel, but the new guidelines, based on tons of research, now strongly recommend more potent, faster-acting drugs like ticagrelor for most people. Clopidogrel, the old guard, is now really just reserved for special cases where those more powerful drugs might be a little too risky.
And this is a perfect example of a major reversal in medicine. You know, it used to be standard practice to give beta blockers through an IV right away to try and protect the heart. But now we know, thanks to a huge study, that in patients who are unstable, doing that can actually cause way more harm than good. It can increase the risk of the heart just failing completely. So the new rule is clear: get the patient stable first.
All right, now we have to shift gears to the most critical scenario of all. What happens when the heart attack is so bad that the heart just stops beating entirely? This is cardiac arrest, and now we're in the world of advanced cardiovascular life support, or ACLS.
The full ACLS algorithm can look incredibly complicated, but honestly, it all boils down to this simple, repeatable loop. You start high-quality CPR, pushing hard and fast on the chest. Then, every 2 minutes, you pause very briefly to analyze the heart's rhythm. If it's a shockable rhythm, you deliver a shock. Then you give drugs, and you go immediately back to CPR. It's this relentless cycle designed to give that heart its absolute best chance to restart.
The 2025 updates have also cleared up two big questions about that drug step. First, for rhythms that you can't shock, you give epinephrine as soon as you get an IV line in. No waiting. Second, for the rhythms that you can shock but just aren't responding, there used to be this huge debate between two drugs, amiodarone and lidocaine. Well, the guidelines now say they're equivalent. Pick one. Either's a perfectly good choice.
And this brings us full circle, right back to the newest and maybe the most important part of these new guidelines. What happens after all the chaos? After the heart is restarted, the artery is open, what now? Well, the focus shifts to life beyond just survival.
This is it. This is that sixth link we were talking about, recovery. The official definition makes it so clear this isn't just about getting someone out of the hospital. It's about a dedicated, focused process to make sure the patient has the best possible brain function and quality of life for all the years ahead. It's a huge shift from just saving a life to saving a person's entire future.
And this isn't just some vague idea either. It involves very specific actions. It means things like carefully controlling a patient's body temperature to protect the brain after it's been starved of oxygen. It means waiting at least 72 hours before making any big predictions about their neurological outcome. And it means a real, long-term commitment to rehabilitation.
So, to wrap this all up, what are the big takeaways from the 2025 guidelines? First, doctors are now on the hunt for those tricky, hidden heart attacks on the ECG. Second, the race to open a blocked artery has crystal clear time goals, under 90 minutes for PCI, under 30 for drugs. Third, the medical toolkit is way more powerful, with huge shifts in the drugs we use. And finally, the ultimate goal isn't just survival anymore, it's recovery, making sure that survival comes with a real quality of life.
These new guidelines are an incredible leap forward in how we respond after a heart attack has already started, which really leaves us with one final thought to chew on. As our medical response gets faster and smarter, is the next great breakthrough going to be something that happens in a hospital? Or is it preventing the attack from ever happening in the first place, a breakthrough that might just lie on our own hands?